Okay, we'll be starting now. Good morning once again, everyone. Seeking the blessings of His Holiness, Sri Shivaratri Deshikendra Swamiji, I welcome you all to today's webinar hosted by Department of Periodontology, JSS Dental College and Hospital, Mysuru, which is one of the constituent college of JSS Academy of Higher Education and Research. I am Dr. Avinash and I am reader in the Department of Periodontology. I'll be the moderator for today's webinar. We all would have brushed our teeth in the morning, isn't it? And we know that we brush our teeth to remove plaque biofilm which is formed on the teeth. As dentists, we know that plaque control can be classified as mechanical plaque control and chemical plaque control. While we are very familiar with the brushing techniques, there are a lot of misconceptions about chemical plaque control. For example, when to prescribe chemical plaque control agents, whether we need to use it routinely. I'm sure many of you would have these questions in your mind. In order to clear these doubts, we have organized a webinar on this topic, which is chemical plaque control, busting the myths. We shall begin today's program by virtually lighting the lamp. Lighting the lamp signifies that we all bow down to the knowledge and it removes our ignorance. Sumuk, can you please play the slide? Thank you, Sumuk. Today, we have Dr. Tihana Divnik-Resnik, Senior Lecturer of Periodontics, University of Sydney, to speak on this topic. On behalf of JSS Dental College and JSS Academy of Higher Education, a warm welcome to you, Dr. Tihana.
Thank you very much. Thank you for inviting me. It's my pleasure.
Thank you. We are glad to have Dr. Kushalappa, Director, Academics of JSS Academy and Higher Education and Research amongst us as our chief guest today. I welcome you, sir, for all the support rendered by you.
Thank you. Thank you, Avinash.
Yeah. We also have our external panelist, Dr. Harsha MD, Professor and Head, Department of Periodontology, Hasanamba Dental College and Hospital, Hassan. We welcome you, sir. We have always received encouragement and support from our principal, Dr. Ravindra, for any activities we conduct in the department or from the college. We welcome you, sir. We also have our head of the department, Dr. Deepika, who will be our internal panelist for this webinar. I request Dr. Ravindra to speak a few words about today's webinar.
Good morning, everyone. Seeking the blessings of His Holiness Swamiji, Chief Guest of the Day, Dr. Kushalappa sir, and our external panelists and our own student alumni of JSS Dental College, Dr. Harsha, and head of the department, Deepika, Madam, and organizers from the department of Perio, all the staff, faculties, and students. Chemical plaque control is one of the main, as Dr. Avinash puts it, we have to know when to prescribe, when not to prescribe. Right? That is the thing which everybody should know. Many times what happens, they prescribe the unnecessarily also, which will have a side effects. So today we have Dr. Tihana, she is going to tell us and highlight us about this chemical plaque control. I once again welcome heartily to on behalf of JSS Dental College as well as JSS Academy of Higher Education, and thank you everyone. Have a nice day.
Thank you.
Thank you, sir. Thank you. Now I request Dr. Kushalappa to say a few words and give opening remarks.
Thank you, Avinash, seeking the blessings of His Holiness Swamiji. I, first of all, warm welcome, in addition to what the Dean just said, a warm welcome to especially Dr. Tihana Divnik. It's nice to have an international resource person with us. And Dr. Harsha, very own alumni, and I can see two people from Hassan, you and the Dean. The Dean is also older Hassan and our man also. So two people there, and and Avinash and Deepika. Warm good morning to all of you. And as a dermatologist, there's very little I can add to what the experts are going to talk on the chemical plaque and its control. But all I can say is the Department of Periodontics is doing a wonderful job, and they are highlighting to all the people who have joined the webinar today how important it is to control disease in the body by the control of plaque, and how much the periodontal health adds how much it helps in the overall health of a person. And especially we've seen now, we have seeing in diabetics, it's a two-way phenomenon where the increasing diabetics causes a lot of periodontal disease, and how the control of periodontal disease can also control diabetes. I'm very happy that the dental college is doing a good, especially the Department of Periodontology is doing a good work on oral health care, and its health, its involvement in the control of diabetes. So I think there'll be a lot of things for the participants to learn from this webinar, and to have first of all from the JSS Academy of Higher Education and Research. I bring warm greetings from my Pro-Chancellor, my Chancellor, my Vice Chancellor, and my Registrar, and all the other senior members in the university, and especially to Dr. Tihana Divinich and Dr. Harsha. I bring a warm welcome from the university, and we are happy to have you all. And I think the Dean can have Dr. Tihana more often in this webinar, because we have found a good way of communication during the pandemic has taught us to be technologically self-sufficient, and have more webinars where we can have speakers of the quality of Dr. Tihana over here. And Dr. Harsha, you need not come all the way to Mysore, although we would love to have you someday in Mysore. And on behalf of the university, I extend a warm welcome to both of you to visit us any time when the pandemic allows us to do so. Congratulations to the Department of Periodontology, especially to Dr. Deepika and Dr. Avinash and the rest of the team, and especially to Dr. Ravindra. Good job, sir, your own department also. So you must be very happy with the work going on. I wish the webinar and the participants a very fruitful academic discussion. Thank you so much for inviting me.
Thank you.
Thank you so much, sir. Thank you for your encouraging words. Okay. It's now time to introduce our external panelists for the day, Dr. Harsha MD. Dr. Harsha has done both his BDS and MDS from our own institute, that is JSS Dental College and Hospital. He has worked as faculty in various capacities at MS Ramaya Dental College, JSS Dental College, Dayanand Sagar Dental College, and Hasanamba Dental College. Currently, he is professor and head of the department at Hasanamba Dental College and Hospital, Hassan. He has many publications in national and international journals. He is also research faculty for teachers training programs conducted by Rajiv Gandhi University of Health Sciences, Bangalore. He is also a trained ITOP teacher. ITOP stands for Individually Trained Oral Prophylaxis. There are many more accolades of Dr. Harsha, which probably I would not be able to mention now due to paucity of time. Welcome, Dr. Harsha, once again. Thanks for accepting our invitation to be external
Thank you very much.
panelist.
I'm privileged. Thank you very much.
Now, I'll be introducing our speaker for today, that is Dr. Tihana. Dr. Tihana is a senior lecturer and doctor of dental medicine and course coordinator in the discipline of periodontics at the University of Sydney, Australia. She has extensive international experience in education as well as clinical experience as specialist of periodontology and oral medicine. She has published her work in several international journals and presented it at numerous professional conferences. She is a member of European Federation of Periodontology, Australian Dental Association, Australian Society of Periodontics, and Fellow of International College of Dentists. We welcome you, Dr. Tihana, once again. And the stage is yours now. You can start sharing your slide.
Okay, so thank you very much for your kind invitation first, and it's my really privilege and a pleasure to have the opportunity to share some of the knowledge with you today. So, okay, I will share the slides. Okay, so can everybody see the slides?
Yes.
Yep.
Yes.
Okay.
Yeah, we can see.
So we are ready to start. So what I'm going to do today is I will just provide an evidence-based update on commonly used oral antiseptics in daily dental practice. I will talk a little bit about the mechanism of their action, also elaborate on indications for use, and also it's very important to mention and discuss their adverse effects. I will also discuss and controversies and try to answer some open questions related to oral antiseptics use in dentistry and in periodontics, and also explore new directions in designing mouth rinse or rinse of the new age. So whenever I'm talking and lecturing my students, first of all, I would like them to understand the basic differences between the antiseptics and antibiotics. Sometimes there is a little bit of confusion about that. So we all know the antibiotics can be used as local and systemic agents, while antiseptics are commonly used as a topical agents in humans because some of them may be potentially toxic, and also it depends on their concentration. If we are taking a look at the antibiotics, we all know that they are specifically targeting bacteria, not other microorganisms. While antiseptics are having a broader spectrum of activity, they may target bacteria, but also fungi, viruses, protozoa, and so on. Also, when we are discussing the mechanism of action, antibiotics are more specific. They're usually targeting specific targets within the bacterial cells, such as either specific synthesis of proteins or metabolism of nucleic acids, or they are targeting special sites on the cell walls, while mechanism of antiseptics is mostly non-specific. So they often have multiple intercellular targets, which reduce the likelihood of resistance development. So we all know that we would like to reduce the use of antibiotics because bacteria can be resistant. So we are just trying to use them as per indication and in a higher concentrations for a shorter period of time in order to achieve the result and to reduce the possibility of resistance development. If we take a look at the both antiseptics and antibiotic, we can say that they can both suppress the growth of microorganisms, so they can act as bacteriostatic agents, but also they can kill the bacteria and other microorganisms. Therefore, they can be bacteria or microcidal. Okay, so if we take a look at the contemporary model of host microbe interactions in the pathogenesis of periodontitis that's been relatively recently published by the Journal of Clinical Periodontology and presented at the latest Europerio in 2018, we can say and we can see that everything starts with the biofilm. So not all the biofilms are pathogenic. So we know that biofilm, it is if the biofilm is removed on regular basis, it will be in equilibrium with our host response and we'll have a clinical health. However, with a little help of behavior risk factors, environmental risk factors, and maybe with the help of susceptibility, if we are not maintaining oral hygiene quite well and if we are leaving the biofilm to keep accumulating on our teeth, it will become dysbiotic. And as dysbiotic, microorganisms within the biofilm can cause host immune response and also can cause the damage. So we all know that gingivitis is a first step to further damage, and we all know that gingivitis affects only soft tissues around the tooth. So it affects the gingiva, and most common is a plaque-induced gingivitis. So if we don't treat the patient, as we all know that gingivitis is reversible, once we reestablish the good practice of oral hygiene, we use, if we need oral antiseptics, we may reverse the gingivitis into healthy tissue again, and we can establish or reestablish the health. However, if we are late in this phase, and very often our patients are not coming because they're not quite scared, a little bit of bleeding didn't kill anybody. So usually they don't come. But then if the gingivitis is left like that, and if proper oral hygiene is not reestablished, we are getting to this side of the chart, and patient is more likely to have a deeper damage and further attachment loss and the bone loss, which will create the clinical feature of periodontitis. Once we get into this red zone and the patient has a periodontitis, we never can come back. We can never restore pristine health that we had in the beginning. No matter how sophisticated surgical techniques, bioactive substances, and the bone grafts, membranes we have, we usually fail to restore the full health. So that's why the periodontal patient is always periodontal patient, and they should be monitored. We should be reminded to maintain the oral hygiene, come for the regular maintenance or supportive periodontal treatments, and in order to prevent the recurrence and further progression of the disease. So that's very important. Also, when we go back to the biofilm, we all know the biofilm can populate the crowns of the teeth, dentures, all other non-shedding structures and tissues in the mouth. But also we have a biofilm that's hiding below the gum line, the biofilm that is sitting in the periodontal gingival pocket or a sulcus. So the plaque that's found on the crown of the tooth and plaque that is found in the periodontal pocket, let's say, are quite different. So supragingival biofilm harbors streptococci mutants. It can have some other bacteria that are most commonly aerobic. Those bacteria are fermenting carbohydrates, and also if you eat more sugary food, they have a more food for themselves, and they fermenting the carbohydrates into the acids. So these microorganisms are thriving and developing in the acidic environment. They also produce extracellular polysaccharides that will further bind them to the tooth surface. But on the other hand, these microorganisms and biofilms are usually localized on the crown and easily accessed by the mechanical plaque control and also chemicals if we need them to use. But if we get down into the periodontal pocket, those biofilms are quite different. They don't like acids. They don't care about the carbohydrates. They don't ferment them. They don't produce extracellular polysaccharides, and they are not firmly and tenaciously attached to the tooth surface. They are distributed into niches. So one type of biofilms are attached to the usually root surface or cementum surface. Some of the biofilms are freely floating into the area of periodontal pocket, and some of the biofilms are attached to the soft tissue of the periodontal pocket, even though some of the bacteria are such pathogenic so that can penetrate into the between the cells and also penetrate even into the bloodstream. So we have to be really careful when we are considering biofilm, and especially bacteria in biofilm are 1,000 times more resistant to chemicals than in their planktonic forms. I'm sure that you have lots of your patients coming asking for implants. Implant therapy is very common and very popular today. And believe or not, majority of my patients with very severe periodontitis, they are coming to me and saying, okay, I'm fine to lose my teeth. You can extract them, but I want them to be replaced with implants because implants are very strong, implants are safe, and I won't have any headache or problems after I get the implants. This is wrong. This is problematic as well. So implants are not resistant to peri-implant diseases, unfortunately. Once implants is inserted and abutment is placed, also restoration, the race for surface starts. So all oral bacteria are also colonizing the surface of usually abutment and forming a biofilm. And if we don't maintain oral hygiene as we should, the biofilm will cause the damage. First, it will cause the inflammation of surrounding tissues around the abutment, which is called peri-implant mucositis, which is similar to gingivitis, which means that it is still reversible. And if we react on time and treat the mucositis, it will reverse and we will be fine. However, if we miss that opportunity and if the patient still keeps the biofilm on the implants and not establishing good practice of oral hygiene, this My peri-implant mucositis is more likely it will progress further. We will lose some of the bone, some of the osseointegration, and then we will have a failing or barely surviving implants with the problems such as suppuration, deep probing depth, and so on. And we all know that peri-implantitis, even though very similar to periodontitis, because the both diseases are inflammatory diseases, complex diseases as well, we all know that treatment is also very complex and complicated. And even it's less predictable. Treatment outcome is less predictable when we are talking about and treating implants as compared to teeth and periodontitis. So we all know that peri-implantitis, maybe only initial forms may respond well to non-surgical therapy with antibiotics and antiseptics, but more advanced forms of peri-implantitis, we have to raise the flap, we have to clean properly implant surface, and even though after that thorough surgical treatment, maybe we fail to save the implant. So that's why our patients have to be very careful about that, and they have to be warned and educated that implants are not the end of their issues. And especially if they had a previous history of periodontal disease, it's more likely that they will also suffer from some of the peri-implant diseases in case they are treated by implants. Also, if you take a look at the recently published clinical practice guidelines from a European Federation of Periodontology, published last year, you can see that they published the practice guideline for the treatment of stage 1 to stage 3 of periodontitis. And they suggested that we always start with the step 1, which starts with preventive measures and education. So preventive interventions to control inflammations are the most important. And if we fail to deliver this phase to our patient properly, if we fail to teach them how to properly maintain and establish oral hygiene, then we'll fail the entire pyramid. So all these pyramids will get down, and of course our treatment outcome is going to be insufficient or ineffective or unsuccessful. We're not going to be happy. Patients are not going to be happy as well. But second step is usually refers to supragingival instrumentation and removal of subgingival biofilm and the calculus. And step 3 usually includes the more complex surgical procedures. And the step 4 is the crown or the tip of the pyramid. It relates to mechanical or to maintenance phase or supportive periodontal treatment. And as you may see, the European Federation of Periodontology suggests the adjunctive use of antiseptics in certain phases of the treatment. And also what they emphasize that antiseptics should not be routinely used, but only regarded, each case should be regarded as a separate. And also we have tailor their treatment and tailor their chemical plaque control individually. So in some cases we might not need them, but in some cases they may be helpful. And it's best when they're used as adjunct to mechanical plaque control or mechanical treatment. Okay, so this slide is very interesting because I tried to find something to classify the oral antiseptics, and I found in the British Dental Journal this classification, which maybe you can use them to help you to make a decision. So the oral antiseptics are classified into 3 categories, A, B, and C. And in A, as you can see, we have substances. These are we are less familiar with these two because in commercial market they are not quite present, but we are all familiar with chlorhexidine. Chlorhexidine has a good substantivity, broad antibacterial spectrum, and anti-plaque effect, and can be used instead of mechanical plaque control, as we would say, as a monotherapy. As a monotherapy, it's very often used after the surgical interventions when patient can't maintain oral hygiene or in some painful conditions that I will reflect on a little bit later. B, present the mouth rinses or our oral antiseptics. They are not always as mouth rinses. Oral antiseptics such as essential oils, cetylpyridinium chloride, and triclosan, they have a low substantivity, but still broad antibacterial spectrum and plaque inhibitory effect that is satisfactory. And they should be used as adjunct, so not as a monotherapy, but as adjunct to mechanical plaque control. And C, you can remember as a cosmetic agent, C cosmetic agents, they have a low to moderate effect on plaque accumulation. And also when compared to placebo can be, let's say, water or stained water and so forth. So they showed a little bit maybe higher effects on bacteria and plaque accumulation. And in some cases, they show that are not superior to placebo. So those are hydrogen peroxide, povidone iodine, hexatidine, and some of the natural products. Okay, so an ideal antiseptic properties are as follows. So it should not be toxic, it should have a pleasant taste, it should have a good antimicrobial potential, should have a high substantivity, it should not cause adverse effects, it should not interact with toothpaste components, and should not promote bacterial resistance. Do we have ideal? Unfortunately, we still don't have that. And that's why this is the image from the Australian market. So I'm sure that your pharmacies are similar and are having a wide range of different kinds of bottles with different color, different size. And I must say, if you take a look at the product, so the active components, and if you try to find some decent evidence in the literature, you might be amazed that there is not so much of the evidence for certain oral antiseptics and their use in dentistry. And that's why we have to be very careful when recommending them. We just can't say to our patients, go and find yourself one and use one that you like the most, because we might be wrong. My patient might be allergic to some of the components. My patient maybe won't like a taste, might have a dry mouth problems, and so forth. So as we are tailoring mechanical plaque control according to our patient's need, we have to also, when we need chemicals, we must also take into consideration patients' oral condition, diagnosis, indications, and also their individual needs as well. Okay, I will go back to this. If you take a look at the shelves, you will see that mainly we have mouth rinses. So as we all know, the oral antiseptics are manufactured not only as a mouth rinses, they can be manufactured as gels, they can be manufactured as sprays, toothpastes, usually they're gel pastes, varnishes, and so on. And but the mouth rinses are most commonly can be found on the shelves, and they are very popular among the patient. And also, if you take a look at the literature, this is also Journal of Clinical Periodontology published last year. It's a huge systematic review and meta-analysis of 70 randomized controlled trials of 6 months duration that were participated by more than 6,000 participants. So what they wanted to find out, why mouth rinses are commonly used and whether mouth rinses are really more efficient than other forms of oral antiseptics, toothpastes, gels, sprays, and so on. So they conducted this analysis, and I'm not going too much into this study. If you like, there is a reference, you can read it. But basically, mouth rinses show the better results as compared to toothbrushing with toothpaste. And also, when compared the, let's say, chlorhexidine-based mouth rinses with chlorhexidine-based gels, chlorhexidine mouth rinses performed better. So they were better in plaque control and also better in reduction of the inflammation. Why? Because probably due to its low viscosity, this oral antiseptic in a form of mouth rinse can penetrate everywhere and reach the niches and sites that are really hard to reach with the mechanical plaque control or our mechanical instruments. Okay, so let's start with gold standard. So chlorhexidine is still gold standard. We are all familiar with the chlorhexidine. We all know that it has a very good and positive and also some negative characteristics. This is a molecule of the chlorhexidine, and we know that it has a two positive charges, and which makes it very active or reactive. It reacts with different components, which makes very difficult to us when we want to make a combination of chlorhexidine and other substances, let's say, to achieve this or that result. When we are talking about chlorhexidine, I usually think about the dentistry and its dental and oral uses, but chlorhexidine is used in cosmetic products for personal hygiene, and also it is used as a surface disinfectant, and also it's used in many of the medical products as well. So we are widely exposed to and got used to use of the chlorhexidine. So when we are talking about the spectrum of the chlorhexidine, it has a broad antimicrobial spectrum, so it can affect gram-positive, gram-negative bacteria, including some of the well-known or keystone pathogens, periodontal pathogens, such as Porphyromonas gingivalis, Aggregatibacter actinomycetum commentans, and Fusobacterium nucleatum. And it's also active against the mycetes, such as Candida albicans. So it's a fungi that sometimes gives a hard time, especially if the patients are wearing dentures, are not good with the oral hygiene. It has a small effect on the virus, so it can suppress viruses as well, but it's more successful with microorganisms and some Candida species. When we are talking about the mechanism of action, I want you to think in two directions. So how it works on the bacterial cell, and also how it works with the biofilm and preventing aggregation and accumulation of the biofilm. So we have a different concentrations. So higher concentrations are usually considered the concentrations higher than 0.1%. So in Europe, let's say, it's very popular, 0.12%. In Australia, I'm sure in America, I'm not sure in India, the 0.2% is more commonly used. And those higher concentration, they have an immediate bactericidal action followed by prolonged bacteriostatic activity. At the biofilm or plaque level, these concentrations show to be or have strong anti-plaque and strong anti-inflammatory properties. So let's take a look how chlorhexidine work on the surface and how it suppresses bacteria. So it binds to the surface, external surface of the bacterial cell membrane, and causing the alteration of the membrane. It destabilizes membrane, interfering with the osmosis, allowing the component of the cytoplasm to leak out of the cell. Okay, when chlorhexidine causes more damage to the membrane, it can penetrate and bind to the inner portion of the membrane, further destabilizing and destroying the cell membrane. After a while, the cell membrane is going to be fully destroyed and cytoplasm content will be allowed to leak out of the cell. And that's how it kills the cell. In higher concentration of 2% or 4%, it can also cause the cytoplasm to solidify fully. Chlorhexidine uptake by the cell, microbial cell, is very rapid. It occurs within the 20 seconds after the exposure. So this is very interesting scan image of one of the bacteria. It's a Bacillus subtilis exposed to a chlorhexidine. So we can see this black area, that's a cytoplasm of the cell. The black area presents a cell membrane. So after couple of hours after the exposure, what's happening with the cell? We can see the initial changes that affect the membrane. After a while, membrane is perforated and we can see the cytoplasm leaving the membrane. And after a while, we see the cells are empty. So they are called the ghost cells. So those are the cells, they are not live anymore. So those cells are dead. So that's how the higher concentrations of the chlorhexidine work. If we take a look at the lower concentrations that are lower than 0.1%, and there are formulations all over the world, different, but the less 0.1%, they only have at the cellular level, they have a bacteriostatic action. On the biofilm level, they have only anti-plaque properties. They don't have anti-inflammatory properties. Mechanism of action is very similar. Chlorhexidine in a lower concentration binds to the cell membrane surface, destabilizes it, and allowing the leakage of the potassium and phosphorus out from the cell. So we all know that potassium and phosphorus are very important for growth of the cell, development of the cell, for a function of some cellular enzymes, and also they keep the potential of the membrane of the cell. So once they leak out from the cell get destabilized, and the growth can be impaired, and this lower doses of chlorhexidine actually having static properties but not cidal. So if we take a look at the biofilm level, we all know that we need secondary pellicula accumulated and participated on the surface of the tooth in order to get the bacteria to start colonizing the tooth surface. So chlorhexidine can bind to the tooth surface and prevent accumulation and formation of secondary pellicula, thus preventing the initial or pioneering colonization of the bacteria. It also, in the same time, killing bacteria, reducing their number, viability for biofilm formation. It also circles and surrounds microorganism and can block their systems or receptors that they are using to irreversibly bind to the dental pellicula or other microorganisms in a phase of reattachment or coaggregation. And also in the early stages of biofilm formation, chlorhexidine may knock the calcium ions out from the biofilm, and these calcium ions are known to keep cells together and providing the stabilization of the early of the plaque formation in early stages. So if we observe the chlorhexidine efficacy on the already formed plaque or mature plaque, we will see that its efficacy is reduced because chlorhexidine does not penetrate or very mildly penetrate the already formed biofilm. So that's why when you are advising your patient to use the chlorhexidine or prescribing, in different countries different, here chlorhexidine is just over the counter, so we don't have to prescribe, we just advise the patient to use them. You should remove the biofilm, you should remove the calculus, and also ask your patient if they can to do the mechanical plaque control before they use the chlorhexidine. By doing such, your chlorhexidine will have the best action. Substantivity is other great component of the chlorhexidine. So substantivity in chlorhexidine is very high, which is really good. So substantivity is characteristics of the chemical substances to bind to the, in this case, oral structures, oral mucosa, and to release therapeutic concentrations for a certain period of time. Okay, so for chlorhexidine, which has been shown in vivo and also in vitro and in vivo studies, it can be up to 12 hours. And that's why we are usually suggesting our patients to use, let's say, mouth rinse twice a day to up to 60 seconds. The slides that you showed in the beginning was 30 seconds. That's fine, 30 seconds. Even 20 seconds is sufficient to have majority of chlorhexidine molecules to bind to our oral structures. Why 60 seconds is better to tell to patients? Taking into account the human nature, tell them to use something 20 seconds, and probably they end up mouth rinsing for 10 seconds, which probably is not sufficient. So that's why we usually recommending up to 1 minute in order to avoid this, which usually happens with the patients. Okay, so depending on the concentration, if we have 0.2, usually 10 milliliters is enough, or 0.12, usually 15 milliliters is enough to achieve this 18 to 20 milligrams concentration that is sufficient for good activity of chlorhexidine. Increasing frequency from 2 to 3, 4, or 5 times a day seems not to result in further plaque inhibition. Sometimes I have my patients, they try to be good and say, I am rinsing 5 times a day. I think that's good. There is no need. Twice a day is sufficient. Otherwise, they're just wasting their mouth rinse. with regards to duration of the treatment, I must say we usually base on our clinical experience. So basically for the prevention or as adjunct to treatment of mild gingivitis or minor problems, we usually use it for 2 weeks. However, if we have a more chronic or severe disease or post-operatively, we usually suggest its use for 4 weeks, sometimes up to 6 weeks, but trying to be within the month, not longer. Some of the common indications use in perio and maybe in oral surgery, there are more of these indications, but the most common, I would say, chlorhexidine may be used to prepare the patient before the operation. So we can use as an antisepsis before we start the surgery. In postoperative phase, where regular mechanical plaque control is not possible, very often in perio when we are doing very sensitive mucogingival surgery and we don't want really patient to brush their teeth, we can use a chlorhexidine in that short period of time as a monotherapy. It's interesting, and if you browse the literature, after third molar extraction, you can use especially chlorhexidine gel, 0.12% to prevent alveolar osteitis or dry socket. It is interesting. Dry socket usually is not caused by bacteria. It's just caused by degradation of the blood clot and exposure of the blood. But it's been found that chlorhexidine may also enhance the healing in these situations and prevent a dry socket. Chlorhexidine may reduce rate of postoperative inspections after periodontal or implant surgical procedures, as you all know. And also when we have some acute oral mucosal or gingival infections, such as necrotizing gingivitis, periodontitis, stomatitis, when pain and soreness prevents mechanical plaque control, chlorhexidine may help. We used to use overseas when I was working with the necrotizing gingivitis, periodontitis, we also use a 3% hydrogen peroxide. That's still fine, but chlorhexidine may be used. Most commonly, it's used as adjunct to mechanical plaque control to prevent biofilm formation and its control. After non-surgical therapy, let's say in situations when the patient has post-operative or post-non-surgical sensitivity of gingiva and the oral hygiene by mechanical device is not quite well, we are not happy, we can boost it with the chlorhexidine. And in mentally and physically challenged patients, when mechanical plaque control is insufficient, chlorhexidine may help. And also European Federation of Perio advise the use of chlorhexidine, either gel or mouth rinse, usually gel or swab imbibed with the chlorhexidine mouth rinse in case of these patients, especially in the acute phases when their hygiene can't be properly maintained. Candida and infections related to Candida, also chlorhexidine may help. Very often can be used as adjunct to antifungal agents, and also denture can be disinfected in mouth rinse based on chlorhexidine. Very often we find that gel is more convenient for these patients to use, so they can squeeze the gel into the base of the denture and then put the denture back into the mouth. Bad breath or halitosis can also be treated by chlorhexidine, but only if it's of local origin and bacterially induced. You know that halitosis or bad breath can have intra and extraoral etiological factors, and only intraoral that are related to and caused by some sort of bacteria may be controlled by chlorhexidine. So we all know that every time we are talking about the chemicals, no matter if they're antiseptics or antibiotics, we have to bear in mind adverse effects. Unfortunately, chlorhexidine, even very good in plaque suppression and prevention of inflammation, it has some of the adverse effects. We all know that this brownish or dark staining of teeth, dentures, or dorsum of the tongue is quite annoying, especially for the patients. They usually come to you to make their teeth look better, but after a while they get the brown teeth, so it's quite disappointing with them. And even it will get even more stain their teeth. They're going to be even more strained if they are using iron supplements, wine, tea, coffee, if they are smoking during the time they're using chlorhexidine. Potential to stain rapidly increasing if we are using the concentrations more than 0.1%, and also the length of time plays a role. The longer we're using them, there is a higher potential to stain. Luckily, brown discoloration can be easily removed by professional prophylaxis. There is also another unpleasant adverse effect that may happen. It doesn't happen quite often, but some patients may experience that. Chlorhexidine may interfere with the activity of taste buds. And after a while, patient can complain, look, I don't feel my food is quite tasty as it used to be. So it is also reversible, and after they should be advised to immediately stop using a chlorhexidine, and then their taste will come back. Also, temporary sensation of burning and drying of oral mucosa can be additional adverse effects, and very commonly are related to mouth rinses or products with the chlorhexidine they contain alcohol. Could be that alcohol potentiate these adverse effects. Desquamative lesions, erosions of oral mucosa are quite rare. Usually if the patient is overusing a rinse or products or abusing, in that case that can cause some of the damage to the mucosa. And swelling of the parotid gland also may occur, and it's also reversible. So one question that I would like to discuss with you today is that some of the companies actually and manufacturers tried to incorporate some substances and add them to the chlorhexidine mouth rinses or other products to minimize or fully prevent the discoloration. So there are different systems that are in a game today. And one question that I would like to answer is, do they really work? We all know that chlorhexidine, when combined with the substances, may interact with them and may block them and may block its own activity. So discoloration origin is not quite well understood. So there are a couple of theories and mechanisms that not 100% sure of. So first is a Maillard reaction. The other one is formation of pigmented metal sulfides. Both of these are not supported in vivo. So they've been supported in vitro, but not in vivo. However, products of chromogenic food and beverage, such as tea, coffee, red wine, ketones, and aldehydes, may react with chlorhexidine and form a colored products that may cause a staining. This, though, been demonstrated in vivo and in vitro. So what are the companies trying to do now is to either reduce the concentration of chlorhexidine, as we know that less than 0.1 is less likely to stain, and combine with other substances that may have antiseptic properties and use as a synergistic product. But also some of the companies formulated specific what they call anti-discoloration substances or systems that they incorporated in with chlorhexidine. So our questions was, when chlorhexidine has some additives such as anti-discoloration substances or systems, does it still work? And do these systems actually prevent staining? And the latest one that I found is 2019, again, systematic review and meta-analysis. And it assessed the 13 papers and found out that quality of evidence was moderate. So all these research studies used either chlorhexidine with additions of anti-discoloration systems and compared to chlorhexidine without these additives. And what they found that addition of anti-discoloration substances to chlorhexidine mouth rinses does not affect its efficacy. Okay, so they are still efficient as chlorhexidine without any additions, and those substances are reducing staining. They can't prevent fully staining, but they are significantly reducing the staining. And also when these studies emphasize that it is very important to remove the biofilm and calculus before we start using chlorhexidine, because that definitely can increase adverse effects, especially related to staining caused by the chlorhexidine. Okay, what other questions may come to my mind? And usually my students are asking, what should I do first? Should I advise my patient to rinse them out first and then clean with toothbrush and interdental devices, or should I do either way? Suggest them to brush teeth, clean interdentally, and then use a mouth rinse. So also I browse the literature and you will find lots of the studies. They are mostly in vitro studies. There are also in vivo studies that I'll show a little bit later. So some of the in vitro studies found that the chlorhexidine is even CPC, they tested both of antiseptics, are actually most efficient when they are used after toothbrushing. Not prior, but after toothbrushing. And also what studies found that after use of antiseptic based on chlorhexidine or acetylpyridinium chloride mouth rinse, do not rinse mouth with water. That's what I usually advising my patients. Please don't eat or drink or use anything or rinse mouth at least for half an hour after you use a mouth rinse. Also, one question that is very interesting, it's interaction of chlorhexidine and toothpaste, because we all know that bubbling toothpaste, not the gel toothpaste, they don't contain SLS, but bubbling and foaming toothpaste, they contain sodium lauric sulfate. And sodium lauric sulfate, you can see this bottle has a chlorhexidine, this bottle has sodium lauryl sulfate. After they get together, after 24 of incubation, you have a salt and they precipitate. So chlorhexidine is inactivated and they precipitating and chlorhexidine doesn't work anymore. So basically, SLS block chlorhexidine and precipitate, and also in the mouth, it can inactivate chlorhexidine tooth complex. So now it is clear that after toothbrushing with the toothpaste that contain SLS, what's the further steps when we need to use chlorhexidine? There are in vivo studies. Again, I don't want to get into depth of the studies. It's very important to pay attention to study design of those studies, because the design was a little bit awkward. So, so let's say, in other words, if you're using SLS containing toothpaste, what you have to do after you brush your teeth with the SLS containing toothpaste, rinse it with water, get rid of SLS, and after that, you don't have to wait. You can use chlorhexidine-based products immediately. But if you decide not to rinse your mouth with the water, so let's say you want these fluorides to keep longer on your teeth, in that case, you have to wait at least half an hour, even 1 hour before you use chlorhexidine, because otherwise they will interact and chlorhexidine will have reduced efficacy and you won't get the results with the chlorhexidine that you expected. Okay. So other adverse effects that I would like to emphasize, and now we are becoming more concerned about these adverse effects, are hypersensitivity reactions. So when I was students, usually it was, yeah, chlorhexidine, local allergy is possible, systemic allergy is less likely, very, very rare. But now there is incidence is on the rise, especially in United Kingdom. And if you read some of their journals, you will see that usually patients, those are medical patients, they are not, the allergic reactions are very rare in dental settings, but medical patients, they are usually hospitalized for a longer period of time, exposed to chlorhexidine, they may develop and become allergic and also develop the anaphylaxis, which is life-threatening. We may be aware that chlorhexidine is used in various concentrations in many products. So let's say in Australia, there are 157 chlorhexidine-based products. So chlorhexidine is used in the central venous catheters and also in urethral gels in different concentrations. For surface disinfection, environmental disinfection, usually higher concentrations are used. And therefore now the companies are trying to reduce the use of chlorhexidine or even replace with some other products to avoid and prevent the severe hypersensitivity reactions. One more problem related to chlorhexidine that has not been noted earlier, but now it is emerging more and more, is microbial resistance to chlorhexidine. So there was a notice that some bacteria, such as Klebsiella pneumoniae, some of their isolates became resistant to chlorhexidine, but also not only to chlorhexidine, they developed a cross resistance to some of the antibiotics. In the same manner, some of the oral microorganisms showed to be resistant to chlorhexidine, and at the same time to some antibiotics, as well as some of the Candida albicans species. So probably this prolonged exposure to chlorhexidine might cause development of more and more microorganisms that might be resistant to chlorhexidine, with some of the cross resistance to antibiotics that for us might be difficult to control. So basically, in order to maybe prevent and avoid these, some companies are trying to, and researchers are trying to explore new avenues and new roads to check whether we can get back to nature maybe and do some extracts from the nature that may help us to reduce chlorhexidine use, or maybe even to replace the chlorhexidine in all our products. Oops, sorry. So basically what we are trying to do is to reduce adverse effects of chlorhexidine by reducing concentration. We try to reduce use of alcohol, so we're trying to get back to nature fully, prevent formation of microbial resistance by aiming different targets in microbial cells. Chlorhexidine combination with some other agents may actually enable this. And also, if we have two potential agents in one bottle of the mouth rinse, maybe we can increase their potential of antimicrobial efficacy. So basically, we are going back to nature, as there are so many plants that are used for medicinal purposes, and only 15% of those plants being actually used, and there are more plants there that may help. So we all know that citrus fruits are full of good substances, especially fibers and vitamins. We all know that scurvy, that was a problematic problem in the past, was is prevented and treated by vitamin C. Also, citrus fruits can prevent some of the kidney diseases, also lower blood pressure. They're also good to modulate or reduce inflammatory process. And in the last few years, phytopharmaceuticals are having an outstanding role in the new drug discovery. So there is one interesting thing about some product that is being patented and used as even as a sanitizer and even as oral antiseptic is it Citrox. So it's composed of bioflavonoids, and bioflavonoids found in citrus fruits have been widely recognized to have diverse biological and health promoting effects. They are not only found in citrus fruits, but other plants as well. So in vitro and in vivo studies show that they can have an immunomodulatory activity. They can act as anti-inflammatory agents and can have anti-mutagenic capacity. They are also powerful antioxidants, which is very important. They can increase vascular or capillaries resistance. They also can support a wound healing, which is good after the surgical procedures. They have neuroprotective ability, which is not quite relative to oral use, but still it's very, very important, their capacity. So Citrox is a bioflavonoid complex derived from the pith of Citrus aurantium, which is bitter orange, and it contains 9 bioflavonoids. So how products is fabricated? So the pith and pulp of the fruits is dried and ground, pulverized into the powder, and is sold in water, and then further processed and mixed with food-grade natural acids. Natural acids are using stabilizing and also serves as a preservative of the Citrox. So Citrox has an antimicrobial, antioxidant, and anti-inflammatory potential. So Citrox does not contain alcohol, but these 3 acids. Acids also regulates the pH of the rinse, and also they enables the proper environment for the bioflavonoids to be the most active and efficient. So if we take a look at the mode of action, again at the bacterial and biofilm level, so we can see that citrox can inhibit of cytoplasmic membrane function. They can inhibit certain proteins that are very important for transport of material and nutrients through the membrane, and also alter membrane permeability, allowing the potassium to leak out of the cell. So that mechanism is very similar to chlorhexidine. However, citrox can also inhibit energy production and metabolism, and also can suppress supply through blockaging of energy of nutrients and metabolized in and out of the cells. And also they can extract some enzymes and toxins and virulence factors, and thus reduce the pathogenicity of microorganisms and biofilm in total. So basically this mechanism is quite different than chlorhexidine mechanism and may be potent against antibiotic resistant microorganisms. Also, citrox may have indirect antibacterial mechanism of action. It can boost and support macrophages and stimulate our host immune response. And at the biofilm level, it function is really similar to the function of chlorhexidine. It can inhibit attachment and biofilm formation on the surface of the tooth. There are lots of in vitro study. If you take a look at the citrox, it's been tested on its own, but also with combination in with chlorhexidine. So the most recent study that's relevant to dentistry was published by Skulan in 2020. So they used, unfortunately, in vitro design. There is no still in vivo studies, but in vitro design, which was really interesting. So they formed a karyogenic biofilm and periodontal biofilm. So they are quite different, as I elaborated a little bit earlier. And they tested different mouth rinses with combination chlorhexidine and citrox, and chlorhexidine was of different concentrations. You can see 0.2, 12, and also 0.09%. They tested also the gel and compared against the placebo and against the other products with chlorhexidine of the same concentrations, but without additive, without citrox. And what they found, actually, they found that chlorhexidine formulations with citrox were as or more active as the same concentrated chlorhexidine without any additives. And the final conclusion was that citrox seemed to augment the antibiofilm properties of chlorhexidine with regards to biofilm formation. So basically this combination can gives and also show the promising results, but we can't recommend anything without more studies. And especially what we need more in vivo studies to also test how patients are accepting the mouth rinses, chlorhexidine, citrox, and also if there is any staining potential, less staining potential with this product, and also to test many other things that we would. So this is promising, but only in vitro studies we have so far, and initial findings are promising, I must say. Second in a row, and second to the best, as the best and gold standard is chlorhexidine, is essential oil-based products, usually manufactured as mouth rinses under commercial name Listerine. So we all know that Listerine became popular in 1920s, and it's still very, very popular around the world. So it's been commercialized and advertised as a mouth rinse that prevents and treats bad breath, halitosis. And you know that bad breath is something that prevents us from socializing. So they took a young ladies, okay, if you have a bad breath, you will never get married. So Listerine can be actually an answer to your problems and solution for your problems. And that's marketed quite easily. And that's how it becomes very, very popular since 1920. So that's a little bit of history and story about the Listerine. If we take a look at the antimicrobial spectrum, it has a broad spectrum, and also it's active against some viruses. So mechanism of action very similar to chlorhexidine. In higher concentrations, it disrupts the cell wall and precipitates cell proteins, thus killing the cells. And in a lower concentrations, it can inactivate essential enzymes in bacterial cells. So it also interferes with plaque formation and maturation, and also it can extract the endotoxin from gram-negative pathogens, thus reduce pathogenicity of the biofilm. It is capable to penetrate the plaque mass and exert antimicrobial effect on bacteria growth within the biofilm. That's something that is superior when we are talking about essential oils, but usually it's believed it is because the alcohol in the mouth rinse is based on essential oils. So if we take a look at the further and some other studies, we can say that within the 30 seconds, it's very effective against the periopathogens. Also, it is effective against some of the viruses, enveloped DNA, such as herpes simplex type 1 and 2, and influenza virus, which is enveloped RNA virus. Also, it is very effective against the Candida albicans, and in vitro, it can reduce it up to 100%. When we are talking about the penetration, there are a couple of studies, and then they actually observe the biofilm and layers of the biofilm and monitor the bacteria, whether they are alive or dead. So live bacteria, they are stained with the fluorescent dye. They usually stain the green. Dead bacteria are stained in red. So when they observed and exposed first to the essential oils and to placebo and observed these layers of the biofilm, they found that 78% of bacteria were dead when treated by essential oils, as compared to 27 following treatment with the placebo. So that means that essential oil acts really good on the mature film and better than chlorhexidine. But compared to with the chlorhexidine is always the better and the first choice, and essential oils are following the chlorhexidine. So essential oils having also anti-inflammatory properties, as we know phenolic compounds of essential oils have anti-inflammatory and also reducing synthesis of prostaglandins during the inflammation. They also act as the scavengers of the free oxygen radicals and may affect and improve leukocyte activity. There is a little bit suspicion related to substantivity of the essential oils. So if you take a look at the studies, in vitro studies, they show that the essential oils substantivity is far more or inferior than the substantivity of chlorhexidine. But the study conducted by Fine and colleagues, which is a clinical study, they basically show that essential oils may remain active and actually suppress bacteria, especially the volatile sulfur compound producing bacteria, for up to 12 hours. And that's why when we are suggesting or prescribing essential oil-based mouth rinse, and as per manufacturer also recommendation, essential oils or Listerines usually use the 20 millimeters of Listerine twice a day for up to 30 seconds, because we assume that substantivity can be a little bit more than has been shown in vitro studies. There is one popular and several studies actually published by Sharma and colleagues, where they tested and then wanted to find out how much Listerine is successful in suppression of interdental biofilm and in preservation and prevention of the interdental papilla inflammation. So they compared toothbrushing and the toothbrushing and flossing with Listerine, toothbrushing, flossing without Listerine with placebo, and also toothbrushing and placebo only. So they wanted to know whether Listerine is less or more superior, I must say, than dental floss. So it was a long-term study, 6-month study, and after 6 months, they came up to these following observations. So the test group that used Listerine as adjunct to brushing and flossing had a 52% greater reduction in interproximal plaque index and 21 greater reduction in interproximal gingival inflammation. And they basically concluded that essential oil-based mouth rinse was at least as efficient as dental floss in controlling interdental plaque and gingivitis. What does it say to us? Perhaps when oral hygiene, interdental hygiene, especially of our patients, is insufficient because of dexterity, low dexterity, and some other reasons, we may reach out for essential oil as a very good adjunct to the mechanical plaque control. Regarding the adverse effects, so essential oils, they are not staining teeth, less likely to stain than chlorhexidine, even in short, but also in long-term period. They don't interact with SLS from toothpaste or any fluorides added to the toothpaste. They are very rare, show taste alterations and hypersensitivity. There is no microbial resistance observed, but they can cause a tingling and burning sensation. Very often it happens due to a higher concentration of alcohol. So if you take a look at this table, which is I found it quite useful, of a professor from University of Melbourne. So see this Listerine mouth rinses containing a high concentrations of the ethanol, and if you compare with the wine and beer, it's some of the mouth rinse products with essential oils contain far higher concentrations of alcohol. We know that alcohol is added to essential oils because it has to dissolve them to activate them. It is used also to preserve the shelf life, and in some cases, especially with the chlorhexidine, it's used to improve the taste because chlorhexidine tastes really bad. But then we can ask the alcohol containing and alcohol free mouth rinses. Do we have that alternative? So basically, if we are talking about chlorhexidine, we all know that there are studies that compared alcohol free and alcohol containing chlorhexidine mouth rinses, and they are equally effective. But what about essential oils? So before I mention that, I would like just to show some studies and concerns about the alcohol. We all know that some concerns were raised in 2000, let's say 7 and 8, and even earlier, where Listerine was actually blamed to cause some problems in the mouth, such as hyperkeratotic white lesions in hamster cheek, or even 2 cases of mucosal white lesions. But if you take a look at this case report and this study, the essential oils or Listerines were used more than it's supposed to be. So this was a case of one lady. She was rinsing and holding a mouth rinse for 15 minutes in the mouth, okay, for a certain period of time. So that's why it caused a problem. And if you browse these studies, you will see that they claim that twice a day use of alcohol containing mouth rinses may increase risk over sometimes, especially in current smokers, in patients who are consuming alcohol, and even in the patients who are not smokers or consuming alcohol. So ethanol is known as a risk factor, and especially its primary metabolic product, which is acetaldehyde ACTA. So after we use mouth rinse or drink alcohol, metabolism of alcohol starts in the mouth, and we get this ACTA or ACTA. ACTA is known to increase the risk for alcohol-related oropharyngeal cancer. But if you browse other studies, you will find that some bacteria producing ACTA, after eating some products such as let's say yogurt or some vegetables and fruits, we will get some ACTA in the mouth. And what they usually say and concluded in these studies and in this relatively recent, very comprehensive review, they said that actually ACTA concentration in saliva briefly elevates after rinsing with alcohol-containing mouth rinse, and this concentration decreases again rapidly to undetectable levels within 10 minutes. So basically, it's a very short period of time that we are exposed. And basically, based on this, mouth rinses with alcohol concentration up to even 28%, even used twice daily every day, have negligible impact on cumulative lifetime exposure to ACT compared to that derived from other sources. So basically, I must say that they are safe, but still, if the patient is smoker, if the patient is alcoholic, if the patient has had a history of oral cancer, if the patient's been treated from oral cancer, patient has a dry mouth, be careful. Try to avoid these alcohol-containing mouth rinses. Do we have a replacement alternative? Yes, there is a Listerine, essential oil-based mouth rinse without alcohol, but we have controversial clinical evidence. So on the left-hand side, there are studies that they claim that Listerine Zero was not superior than Listerine with the alcohol. On the right-hand side, there are a couple of studies run by Italian and Brazilian group that they claim that, yes, it is effective as Listerine, as alcohol-containing Listerine, and as effective as CPC mouth rinse. So at this stage, we can't say more. We can say that only we need more evidence in order to make a final statement whether it is more or less effective than essential oil-based mouth rinse with the alcohol. Just a couple of words about the other less common and less, I would say, popular antiseptics. That's cetylpyridinium chloride, or CPC. Unfortunately, in Australia, it is available in a lower concentration, such as 0.05%, and it's usually used as a cosmetic mouth rinse. It has a wide spectrum on the microorganisms, but when compared to essential oils and chlorhexidine, it is less efficient, I must say. And the problem with the CPC is that it has a very low retention in the mouth. So it's 3 to 6 hours. And if we need it, and if we need to achieve that level that is satisfactory, we would have to rinse 4 or 5 times a day, which is quite difficult with everybody having a very busy schedule. So it is usually used for minor issues, and also as it has a very similar molecule and it's positively charged, similar to chlorhexidine, it should be carefully used after the use of SLS containing mouth rinse toothpaste, because it can interact. It also causes adverse effects such as staining, and very similar are the adverse effects to chlorhexidine, but less, as it has a lower potential. Can it be used? Yes, as I said, let's say after the debridement, when your patient is sensitive and can't maintain quite well oral hygiene, maybe CPC in short period of time can help. Natural mouth rinses, I'm not going to talk a lot about them. They are all based on natural products. Usually they have a combination of various ingredients. Native to Australia is tea tree oil, green tea, can be also incorporated, grapefruit seed oil, aloe vera, echinacea, turmeric, and all other products you know best. But the problem is that we don't have much evidence. We don't have well-designed clinical studies to confirm their efficacy. Oil pooling is very often a question that students are asking me, and it's based on the traditional medicine and advice to swish a tablespoon of some oil, let's say coconut oil, sunflower oil, and other sesame seed oil for a couple of minutes, usually before the breakfast. There is some evidence out there that it can prevent caries, periodontitis, gingivitis, can also prevent and treat even a little bit of cheilitis, angular cheilitis, prevent halitosis, and even xerostomia. But a certain mechanism is still a little bit a question mark. Probably when oil comes into contact with saliva, it can form soaps, and soaps are really good cleansing agents. However, what I can say, we need some more evidence to make a final recommendation. One other question that my students are asking me, can we use mouth rinse and treat and remove the subgingival plaque? How does it affect the subgingival plaque? We all know that if we are normally using mouth rinse and swishing it through our mouth, even if we are using a syringe and irrigating the pocket, usually the efficacy is minimum on subgingival bacterial microflora. First, it's hard to reach that area. And the second, basically chlorhexidine interacts with blood, proteins of blood, pus as well. Some subgingival microorganisms may be less susceptible to chlorhexidine, and also especially P. gingivalis may release vesicles that can bind and inactivate the chlorhexidine. If you want to apply chlorhexidine, you can use Periochip. Unfortunately, I don't have any experience with the Periochip because it's not allowed. It's not TGA approved in Australia, so we don't have it. But Periochip may be an option for subgingival delivery of the chlorhexidine, and also it showed the good results in suppression of flora, and also in improving the probing depth, and also clinical attachment level. When we are talking about implants, there are still lacking of studies, but we all know that some of the antiseptics may help with the treatment, especially the treatment of peri-implant mucositis. They may help with the prevention as well. So especially chlorhexidine in a form of a mouth rinse, or even in a form of gel. When we're having implants, we usually like applying a gel around the implants using the interdental brush. Then it can be used as adjunct to non-surgical debridement to treat peri-implant mucositis, but still we need some evidence. Both chlorhexidine and essential oils, but chlorhexidine is more commonly used. It is more commonly also used to decontaminate the surface of the implants with the when it is imbibed with on the cotton pellet during the surgery, as you also know. But just to mention a couple of words on the use of mouth rinses as pre-procedural rinse and prevention of aerosolization of oral microorganisms. And we used to do it earlier, but now it is quite common because we are in the middle of pandemic, unfortunately, and we all know that coronavirus can also be present in a high load in saliva. And we all know that dental procedures are of a high risk procedures, and we can actually generate, when using airflow therapy, when using ultrasonics, high speed instruments, we can create a certain amount of aerosols. And earlier, to prevent aerosolization of the oral microorganisms, we used, let's say, chlorhexidine, essential oils based mouth rinses to prevent this. However, these products didn't show to be quite successful in preventing and suppressing aerosolization of the coronavirus. So basically what we are usually doing now is mouth rinsing with the povidone iodine, the 1.5% that is recommended, also hydrogen peroxide from 1 to 3%, and also CPC based mouth rinses may also help reduce the viral load in the aerosols. However, some other studies, and I hope that many studies are now in process, they are evaluating the capability of chlorhexidine, but also there are some other substances that may be promising, such as citrox, cyclodextrin, and so on, that may have a better potential to suppress aerosolization and the virus in aerosols when used as a pre-procedural rinsing. So this is just a couple of words on that. And to take home message is that dental professionals should make evidence-based decision to the suitability of particular mouth rinse for a particular patient and his individual needs. And also, please don't use them routinely. So assess each patient, assess the risk, assess the need for the use of chemical plaque control, and then if you really need, prescribe them or advise the patient to use them. So number one is always mechanical plaque control, mechanical instrumentation, and then only if we need chemical, antiseptic or antibiotics, then think about it twice before you use it. Also, don't only say to your patient, go and take whichever you want, whichever you like best. Just advise them to use the one as per their situation in the mouth and as per indication. So as Each patient is different. And also write instructions. So educate them why you are using mouth rinse, and educate them that they should not continue using the mouth rinse the moment you tell them, and they continue using indefinitely. So they have to come back. So you assess the situation, and if they need to continue using, you have to tell them and you have to recommend them. And also write the step by step how to use. Very often they say use it twice, but we don't say how much to use. We don't say how long to rinse mouth with mouth rinses or how to apply the antiseptics. Also, reduce the use of alcohol-containing mouth rinses because we have alternatives. In certain situations, you can use it, but also be mindful the patients who may be sensitive may have some problems and contraindications. And also, as been said in the beginning, that periodontal disease is doesn't stay in the mouth, unfortunately. So bacteria directly or indirectly interact with other system and other systemic conditions and diseases. And now there is, I think, around 57 diseases that may be associated with the periodontitis, and there are more and more emerging evidence. So as antiseptics may be important in prevention and treatment of oral diseases, we regard them as important to prevent systemic diseases as well. So that's with this, I would like to conclude my lecture, and thank you for your kind attention. So I tried to answer the most common questions. I'm sure that there are still open questions that should be discussed and answered. So please, if you have any questions, I'm here to answer them. And also, if you want to have discussion and comments, you are more than welcome to. Thank you very much for your kind attention. Thank you.
Thank you, Dr. Tihana, for elaborately explaining about chlorhexidine and other chemical plaque control agents. Before we move on to the question and answer session, I would request Dr. Harsha to give his reflections on the webinar conducted so far.
Thank you very much, Avinash. Dr. Tihana, I should tell you, I remembered my first sea diving experience. So when the coach actually, ensured that I'm safe, and he took me down and showed each and everything, made me touch and feel and get things under the rock and showed me. So what I meant to say was, it was very clearly evidence-based. Whatever evidence was there, you have very neatly brought it out, and in a very gentle and a comprehensive manner, you have let us know. Most of the questions I read in the question answer box have already been answered by the way you took the presentation forward. I'm so happy with the presentation. Thank you so much.
Thank you very much for your feedback. Thank you. I'm not sure. Microphone.
I'm sorry. Okay. Thank you, Dr. Harsha. Now we'll move on to the question and answer session. There have been many questions asked, and some of these you have already answered, Dr. Tihana, in your webinar. I'll be choosing few questions which are more relevant, which has not been answered. You can just try to answer that. Okay. There's a question by Dr. Pramod, which says, who asked that what is the efficacy of anti-discoloration chlorhexidine mouthwashes available in the market? What is its effect on periodontitis and peri-implantitis?
The chlorhexidine with anti-discoloration system, there are lots of studies with its efficacy on the prevention. And usually when it's a prevention of gingivitis. There is still lacking studies on the prevention of peri-implant mucositis and peri-implantitis. We need some more evidence. But so far, all the evidence that's been gathered until 2019 that I found, they claim that anti-discoloration systems does not hamper the function of chlorhexidine. So the chlorhexidine remains active, even though there is one study published 2015, I think, by Professor Lang. He's a really leading name in periodontology, and he used anti-discoloration system chlorhexidine and compared with placebo. Placebo was water or something like that, and he claimed that it was not active and it was not even efficient. But since then, more emerging studies show that actually chlorhexidine with anti-discoloration system is still effective, and against the perio, and I assume against the peri-implant diseases such as peri-implant mucositis. We can't say about the peri-implantitis because peri-implantitis is very complex, and to treat peri-implantitis we need more than antiseptic. Antiseptic can be used as adjunct to improve the hygiene, because really need to reestablish hygiene of the patient in order to have our treatment successful. But we need non-surgical, and as you know, that in many cases you need to open the flap to decontaminate the implant surface, because implant surface is the problem. Implant surface is rough, intentionally rough, in order to promote also integration, and it is very challenging to clean. So we're trying with titanium brushes with airflow. Now the very commonly used airflow is to decontaminate the surface, but also we can dab chlorhexidine on the surface to reduce the microorganisms. So chlorhexidine with anti-discoloration system, I must say, according to the evidence and to the best of my knowledge, are still efficient, and also reducing staining.
Okay. Thank you, Dr. Tihana. There are many questions regarding how long can we prescribe mouthwash, chlorhexidine mouthwash especially, and can it lead to antibiotic resistance? I think you have answered that one in your...
Most of them are answered, yes.
Yeah. I just want to elaborate on the length of time. It's mainly based on the clinical experience, not based on the studies. But recent review that I read, it was just a narrative review from last year, I think. They said that usually with the chlorhexidine, we should not exceed more than 30 days, let's say 4 weeks. That's something. Lower concentrations, maybe lower than 0.1, they can be used longer, but still we need a little bit more evidence on that.
Right. Okay. There's one more question by Dr. Girish. He asks that, as rightly mentioned, chlorhexidine doesn't penetrate to full depth of matured plaque, but most of published studies where chlorhexidine used as pre-procedural rinse without the use of high volume evacuation system states that bacterial aerosol contamination is reduced by 95%. What could be the possible reason for this when chlorhexidine doesn't penetrate the plaque?
Yeah. So if you regard I usually say to the students, when we take a look at the efficacy of the mouth rinse, we usually test it on single bacteria, that's a planktonic forms bacteria, and in the biofilm. So within the biofilm, which is mature, that means that there is a lots of byproducts of bacteria, slimy matrix, that all of these things are there, and making this biofilm and bacteria more resistant. So that's why the biofilm, it does not penetrate. But when you disperse the bacteria, when they get to the aerosol, they are not in a biofilm anymore. They are single microorganisms, okay, in the planktonic forms, in these droplets, actually, that are very small, and that's why that chlorhexidine may reduce. And in general, when you rinse them out in saliva, you have lots of bacteria in planktonic forms, and it kills them and reduces their number. So that's why it is very effective in reducing microorganisms in the aerosol. Not viruses though, especially not coronavirus that I mentioned in my couple of last slides.
All right, okay. Dr. Vandana wants to know some phytoactive agents used as plaque control or studied as plaque control.
Mm-hmm.
Any phytoactive agents here?
So there's a bioflavonoids. There are different naringin, porcine. There are some of them that are very effective, and they've been shown to reduce the microorganisms and also even reduce the biofilm formation. So that's why I described this Citrox product that's been patented worldwide, and it's used as a sanitizing product. And there are actually two combinations of bioflavonoids in them. So there is one combination that contains also these natural acids, citric acid, ascorbic acid, malic acid, and it's combination without these acids. So that one combination without acids is more active against some microorganisms that you might find on the surface, let's say. And this type of citrox is used as a sanitizers for surfaces, while this one with a special combination of bioflavonoids with these natural acids is recognized to be really effective against microorganisms. So they've been tested on both gram-negative, positive, and some of the fungi as well as single bacteria or single microorganisms and in also biofilms. And citrox showed potential that can actually prevent also formation of biofilms. But I think for dental purposes, it's been tested in combination with the chlorhexidine, and we only have in vitro studies so far. There is one recently, I'm not sure when it's still published, I think it's published online study, where they are using a combination of chlorhexidine and citrox to reduce the viral load of COVID patients with asymptomatics or mild symptoms. And they actually managed with the several times, 2 or 3 times, I think per day, patients were mouth rinse, and then they took their saliva and measure with the PCR the concentration or load of the virus. And after first day of rinsing, they managed to reduce the virus load to a very low level. But continuously, after the continuous 6 or 7 days, the load was slowly increasing. So still we need more studies on the combination. Thank you.
Yeah. Okay, there's one more question asked by Dr. Rajashekar. He asked that can we advise patient to rinse chlorhexidine immediately after periodontal flap surgery? As some school of thought says that it interferes with the blood clotting and also has toxicity to new fibroblasts. So what is your opinion on that?
Yeah, that's quite common question, to be honest. And when I was student, it was, oh, no, don't give chlorhexidine after extraction or anything else. But it is based on in vitro studies again, because the chlorhexidine has been tested on fibroblasts, myoblasts, and osteoblasts. And when in vitro, those cells are exposed to chlorhexidine, they can be quite sensitive. And chlorhexidine, depending on concentration. So I'm not sure about the concentration now, I can't remember them, but in a high concentration, chlorhexidine may suppress or even kill those cells. But this activity of chlorhexidine has not been shown in vivo, in oral cavity. So basically we can start using the mouth rinse, I would say immediately. What I usually say to my patients, if I'm doing surgery usually during the day. So I said to them in the evening before you go to bed, usually they don't have to brush teeth immediately because they won't have a plaque. So before you go to bed, rinse with the mouth, or maybe the day after. So that's quite fine to start with mouth rinses with chlorhexidine without, and I never had any adverse effect or problems with that, with healing or any as such.
Thank you, Dr. Tihana, for answering the questions. There are some more questions due to the paucity of time. Like we'll be answering that one through email. I will personally emailing the answers to you. We have all the questions recorded here. Now I request Dr. Sumuk to display the certificate for the. Okay, so kindly accept the certificate, Sumuk. Yes. Dr. Tihana, this is our gratitude for presenting this webinar. Kindly accept the certificate. We'll be emailing you this as well.
Thank you. Thank you very much. And I would like to say big thank you to all of you, all of panelists, and all for you for inviting me, and also for all of your colleagues and the students that were listening and asking such good and interesting questions.
Thank you so much. Dr. Harsha's certificate. Thank you, Dr. Harsha, for accepting our invitation to be the panelist.
Thank you very much, Avinash. It was my privilege.
Yeah. Okay. Now I request Dr. Deepika, our head of the department, to render a vote of thanks.
Hello. Thank you, Dr. Avinash. On behalf of JSS Academy of Higher Education and Research, I render my sincere thanks to Dr. Tihana Dribnik-Resnik for delivering this talk on chemical plaque control. I express my gratitude to the officials of JSS Academy of Higher Education Research for permitting us to hold this program. I also thank our beloved principal for gracing the occasion. Last but not least, I thank my departmental colleagues and participants. Thanks for attending. Thanks all.
Thank you once again for all the participants and the panelists for being part of this webinar. We'll probably have some more interesting webinars conducted from our department in future. I think if there are, we'll be answering all the questions. So we have your emails recorded. So we'll be sending all the answers which have been unanswered so far. So we shall be ending the meeting. Once again, thank you and greetings from JSS Dental College and Hospital.